Alors, je vais maintenant introduire rapidement le docteur Goscha. Il est le directeur du Center for Mental Health Research and Innovation, donc recherche en santé mentale et innovation. Il détient un doctorat en service social de l'Université du Kansas. Il est le co-auteur avec Charlie Rapp, qui est maintenant retraité, du livre très connu sur le sujet de l'approche axée sur les forces, The Strengths Model, A Recovery-Oriented Approach to Mental Health Services, qui est maintenant disponible dans sa 3e édition. Ses expériences professionnelles incluent la gestion de cas. Il a été responsable d'équipe de gestionnaires de cas de type SIV. Il a été coordonnateur de l'intégration des services, directeur de programme. Il a maintenant plus de 30 ans d'expérience en santé mentale communautaire, cherchant à améliorer les services orientés vers leur établissement à travers l'implantation de pratiques fondées sur les données probantes. Il vit actuellement une transition de carrière et est sur le point d'assumer le rôle de directeur exécutif de l'Institut californien en anglais Behavioral Health Solutions, dans laquelle il est en train de faire des plans pour introduire le modèle des forces de façon très vigoureuse en Californie, tout en demeurant associé au Kansas, où un contrat continue de le lier, l'État du Kansas ayant découvert que si on n'utilise pas l'approche axée sur les forces, notamment les hospitalisations augmentent. Donc, c'est mon grand plaisir d'introduire Rick Goscha ce matin. Merci.
Bonjour à tous. Thank you so much for giving me this opportunity to share with you something that I'm extremely passionate about. And I also want to just acknowledge you all and thank you for your dedication and commitment to the work that you do in improving the lives of people with serious mental illness. When David was 16 years old, he had his first psychotic break. And as if adolescence wasn't enough, he started to feel this discomfort inside of his head. And there was this blurring between what was real and what was not, and a disconnection between where self began and where it ended. Attempts to clarify these blurred boundaries by others was only met with anger, this desperate defense mechanism, protective mechanism to keep himself safe in rapidly shifting sands. And when his own internal safety started to feel unattainable, he considered suicide. Now, these experiences were not met with a compassionate embrace. Rather, they were met with an involuntary hospitalization and forced medications. From there, he went to psychotherapy. He attended psychosocial groups where he learned about this chronic mental illness that he had, the importance of taking medications for the rest of his life, and the importance of trusting in professionals and their recommendations for treatment. But the medications mainly had a sedative effect on David. Now, he was more calm, but he was also more zombie-like. And he was out of the hospital, but life had also started to lose some of its lusters. And hope that once hinged on future dreams, dreams that most teenagers have, started to seem questionable. And 2 years later, David committed suicide. Susan had been receiving mental health services for over 40 years. Her first contact with mental health professionals now seemed like a distant memory. She lived in a residential care facility, but she'd really forgotten what it was like to live at all. She had several friends at one time, or maybe she never really had any friends. She had learned that her perception of reality could not always be trusted. Her only close person in her life was her mother, but her mother was getting older and her health was getting worse. And Susan never liked to be a burden to anyone. And sometimes Susan would go to bed at night wondering why she had been born so broken, so damaged, so incapable, so unlovable. There has to be a better way to do this, and that is the driving force behind the strengths model. The strengths model was not developed because the University of Kansas had the answers. The strengths model was developed because the cost of not doing something was way too great. Merely placing people into services with low expectations, separating them from their communities, trying to remediate perceived deficits, and then blaming people when they're not doing it, is a poor foundation on which to build community-based mental health services. Too many people have given up way too early on life, like David, and too many people have bought into damaging narratives about themselves, lost hope, and have passively resigned their lives over to the mental health system, like Susan. There has to be a better way. The strengths model has a single myopic focus: to help the people that we serve build or rebuild lives that are beyond our formal systems of care, that bring purpose and meaning and positive identity. And it does this by building upon principles and concepts that we're already all familiar with: empowerment, resilience, recovery, finding that fit between the person and their environment. And then it uses practical tools, methods, and practice interventions to help people just begin to make movement in their life. The strengths model rests on 6 core principles. The first being that people can recover, reclaim, and transform their lives. We are absolute poor predictors of who can make substantial gains or strides in their recovery and who cannot. So in the strengths model, we don't even attempt to do that. People practicing from a strengths model framework should approach each person with a non-judgmental lens. And this doesn't matter if a person has experienced 25 years of addiction, or years of homelessness, or who has cycled in and out of the hospital. We view each person through the lens of hope and possibility. The second is that the focus is on a person's strengths rather than deficits. And a misperception of the strengths model is that it ignores problems. And this is not true. The strengths model acknowledges that the people that we serve experience and have experienced significant, substantial barriers, challenges, and problems in their life. The strengths model validates these things for people. But the strengths model is not the happy model. It's not positive psychology. To do this type of work is difficult. To do this type of work is messy. But the strengths model focuses on people's strengths because that is what people possess and build on to somehow navigate the difficulties in their life. And this holds true for all people, not just people with serious mental illness. The community is viewed as an oasis of potential resources. The strengths model likewise views the community as the place where people recover. Yes, people experience stigma and discrimination, burned bridges, blocked doors, trauma, re-traumatization within our communities. But also, within every community, there are niches where people can also thrive. And the strengths model seeks to find these. The person is the director of the helping process. This does not mean that whatever the client desires, we guarantee that we will provide it and it will happen, but it does mean that we sincerely invest into each person's journey of recovery, taking that time to understand what is meaningful and important to them, and maximizing choice and autonomy whenever possible. The relationship is primary and essential. The relationship between the client and the worker drives everything within this model. Later, I'm going to introduce to you a couple of the tools of the strengths model. And just putting hope-inducing, recovery-oriented tools into the hands of a clinician with poor skills who may be spirit-breaking does not all of a sudden make them recovery-oriented. But if you put these tools in the hands of someone who is philosophically aligned to helping people build their lives and move forward in recovery, they know exactly what to do with them, with coaching and with training. The primary setting for our work is in the community. No matter how good the services are that we have, recovery does not happen within the confines of our buildings. But if we want to help people thrive beyond our systems of care, then we need to have the capacity to help people navigate their communities. And this does not mean that every staff within our programs will be out in the community, but we have to have that capacity within this model to go with people and be a traveling companion with them on their journey of recovery. The strengths model is practiced within a context. And it's important for us to understand where we're going with the model before we even set out to engage with people. Or we put ourselves in this place of reactive services, responding to symptoms, responding to problems, responding to challenges, without really any kind of idea about where we're trying to go with that. So when we think about engaging and implementing this model, we have to think about what is the overall goal of what we're trying to do. Now, I use the word recovery here, and it may be a word that you may like or not like, but what's more important than the word is understanding the concepts behind it. And in the strengths model, what we define recovery is helping people build or rebuild lives that have meaning, purpose, and positive identity beyond our systems of care. And for each person, that's going to be different. So for every person we engage with, it's a search to find what that is for that person, and how do we begin to make movement. So engagement is solely geared to that point of helping to understand more about this person who is in front of us, their essence, what is meaningful, what is important to them, how do they currently navigate their lives. Sometimes things that we view as problems for that person is actually their solution. What is the lens that they currently use to navigate their lives? How can we help to build in hope that there's something that's possible? That not only do we have tangible things like groups and medications and services, but we also have the confidence and the ability to walk along with people, to build that hope of possibility and build alliance where we can tangibly help people in their journey. All of the tools of the model are helped to make this transition from that first point of contact to the point that we're able to help people make movement on this journey of recovery. But I have to be completely clear is that the tools of the model are not the model itself. The tools of the model are only the visual manifestations of all the work that goes on that we do. It's the spirit, the methods, the techniques, the interventions, and they play itself out by using the tools that we use. So who is strengths model case management for? Now, I would love to say everyone. That would be the easy answer. And I do see applicability of the strengths model in multiple different types of ways. The strengths model is something that's not become just a part of my work life, but a part of my personal life. I use a personal recovery plan with my son who has anxiety about going off to college. I use the strengths model tools with my 82-year-old mother who has dementia to help her somehow stay in her own home that she desires so much when she was told 4 years ago that she would have to live in a care facility. But the research that we have, the evidence that we've put together, shows its effectiveness for adults with serious mental illness and also those who have co-occurring substance use disorders. But there's also been promising evidence within the state of Kansas as we've implemented this model, also with transitional age youth. Initial results are very promising in that area, and we also have done one pilot for youth ages 12 to 16. Very tentative early results, but the promise is that people start to make shifts. And that's not only clients, but also workers as well. Who are the primary providers of strengths? The best fit when we think of the tools of the model are those individuals who can be community-based, direct service workers, people that we may call case managers or care managers, community support workers, key workers, those people who have the ability to extend out in the community with people, to help them think of things like jobs, going back to school, being part of their community. But there's promising fit also within other elements of our service system, using the strengths model tools and methods and techniques with peer support workers or supported employment workers to help people find better job matches and job development, supported education, supported housing, and even just practical application for other clinicians that we have within our program. My wife used to work in crisis intervention services and use the strengths model tools. My wife currently is a master's level clinical social worker. She may not be able to use the strengths assessment and personal recovery plan with every person that she works with, but she brings the philosophy to everything that she does in her work. And at times she does use a strengths assessment to help a person reshape a narrative or use a personal plan to help people begin some next steps when they feel completely paralyzed. The strengths model cannot be one of those types of practices that we go and we train people and then we just hope that they do good with it. The strengths model does not just exist in a tiny part of our organization if we want to do it well and if we want to receive the outcomes that we can attain by it. It needs to become something that pervades our organization and something that connects with everything else that we do within the organization. We may have ACT services, but not every person will need ACT services in that level of intensity. And we would hope that people would not get on ACT teams and stay on ACT teams for the rest of their lives. Or people would not get stuck in residential services. Or people would not just take medications without any other thought behind it than to take meds as prescribed. That crisis services wouldn't be our best service within our program. But that all of these things, in a sense, have a purpose and a structure, hopefully aligned to helping people build and rebuild lives apart from our systems that have meaning and purpose and positive identity. And the strengths model can play an integrative role in that, in keeping recovery on the organizational agenda. Now, I would like to say in the state of Kansas that we figured everything out and that we have everything set up within organizations where the strengths model is integrated within the entire organization. And we do have the strengths model in a significant parts of the state of Kansas. But that's not where we started. And an important realization is that when we want to do a model, we want it to happen fast. We want to do it quickly and get it out there, so we want to do training. We want to put the tools in the hands of clinicians and do them with every single person that they work with. But the strengths model is really also about rebuilding our systems and the way our systems think. When we started the strengths model in 1982, it was just a small pilot funded by the state of Kansas. A team of undergraduate and graduate students in one community mental health center. And when the rest of the state learned that we were doing this pilot in this one mental health center, you had two reactions across the state. One was that, well, we don't need to do it because we're already doing strengths. And the second reaction is that there's no reason to do it because it'll never work. But this one community mental health center continued to struggle and learn and figure out how to become a team and work together to impact lives. And the results were incredibly promising. People started to make shifts. People started going back to work. And people started going to school. And people started investing in raising their kids. People started to live outside of the hospital. Right now in Kansas, it says 2016, but that should be updated now to 2017. 16 out of the 27 community mental health centers are now implementing strengths at a high fidelity. And when I say fidelity, what that means is that they adhere to the components that are unique to strengths, that separate what is strengths versus what is something else that we may want to call strengths. And nearly half of the people receiving services in Kansas now receive services from strengths model teams. And so we have the ability to tell the difference between who's doing it and who's not, and we can look at outcomes as well. If we look right now just about what kind of impact this has had within our own state, is that what we see is that the outcomes for strengths model teams are significantly better than those teams that aren't. So as of 2016, our last year of full statewide outcomes, less than 2% of all people on strengths model teams were hospitalized that year, where the state average was 6%. 24% were competitively employed. And that's not transitional work, that's not employment that's employed by the mental health center. This is competitive employment in jobs that anyone else would have. So people going to school, people living independently. If we look at the research for strengths model, there are 10 studies right now that have tested the effectiveness of the strengths model. And 4 of those have been randomized controlled trials, and 6 of those are quasi-experimental pre-post test types of designs. But these are common outcomes that we've experienced across research studies, is that the strengths model does have a capacity to help people stay out of the hospital. It helps people to stay in housing. It helps people to get and keep employment. And it does have an impact on symptoms, even though symptoms are never our primary focus. And a probably most important one is that last one, is that the strengths model having the capacity to improve quality of life indicators. Because what we find with people with serious mental illness and recovery is that symptoms don't always go away. Negative thoughts don't always go away. Anxiety does not always go away. Depression does not always go away. But people learn that they can navigate those things and still move forward in their lives. People can experience trauma in their lives and still have a vehicle to move forward. So if we take the 10 studies that demonstrate effectiveness, if we take most importantly the fidelity and outcome studies out of Kansas from 2004 to the present, and the numerous first-person accounts of recovery from focus groups of people that have received services here, we know that we're moving in the right direction, and that's promising. So what does this practice look like? I'll give a quick case example. When we were implementing strengths model on one particular team, they were starting to use the tools and doing very well in the very beginning. They were typically introducing and working with people that they had good relationships with, people that already had a little bit of hope. people that had maybe some goals of what they desired in their life. But their question is that if the strengths model is going to work, will it work for people like Elizabeth, who had gained a reputation as someone within their program as someone that was extremely difficult? So Elizabeth, back in 2010, when we started strengths model implementation, was 33 years old. She was living with her mother and her stepfather and was not the best environment. She was mostly isolated from the community, but I would say that she was actually completely isolated from life itself. She spent the most of her time in her bedroom, listening to music, thinking of dark thoughts, thinking of narratives of worthlessness. In fact, when she was part of the community, it usually meant that she was actually in a hospital or homeless. She had frequent hospitalizations. So just in 2009 alone, she had 7 hospitalizations at a state level. Uh-oh. What's that? Okay. Elizabeth had frequent calls to crisis services, suicidal ideation. And when she wasn't calling crisis services, she was calling people at the program, wanting to know where people are at, demanding help. She had a history of childhood physical, sexual, and emotional abuse, something very common to a lot of people that are within our services. We don't think so much about the trauma histories that people bring into our work and how important that the strengths model actually recognizes, validates, and responds to those things. When we did go out to do the strengths assessment, Elizabeth reported that she wanted to live on her own, and that was the last thing that her worker wanted to hear. In fact, it was like, please don't. Because we tried this before. In fact, the last time that Elizabeth tried to live on her own, it lasted 5 months. She went off her medications. She started to do extremely poorly. She was disassociating, symptoms. She was evicted from her apartment. She was homeless for 2 months. She eventually went back to the hospital and then went right back to the environment that was already bad for her. Back to living with her mother and her stepfather. But we pressed ahead with a strengths assessment. Can you see this very well? I want to mention that this strengths assessment was not completed in one setting. In fact, if you probably spend more than 5 minutes at a time on a strengths assessment, you've probably already spent too much time. The strengths model tools are tools that are integrated in the way that we work with people. They're not a one-time event. Because the strengths assessment is also about narrative shifting. This strengths assessment here probably took about maybe 2 months to complete, to get this much detail. But Elizabeth did not even see herself this way. Her worker did not necessarily see her this way. But this was Elizabeth. Elizabeth was also the person that I described that had been in and out of the hospital, that called up the crisis services, that lived with trauma. But this was also Elizabeth. So the strengths assessment is about helping to shift narratives for people about who they are. The hope that maybe people actually do possess something that can help them move forward. A strengths assessment is also filled out in a context for people. It's not that you sit down and just do an interview and try to gather information. Relevancy needs to be established. The only reason that Elizabeth allowed us to do a strengths assessment with her is because she believed that we were willing to consider housing. We were willing to partner with her to see what might be possible for her to actually try living on her own again. And her question also was, her question to me was, do you think I can do this? Do you think I'm going to be able to live on my own? And my honest response is that I'm not really positive. I believe you have the capabilities, and as I look at the things that you have within your life and who you are, yes, I believe it's possible, but can I guarantee anything? But the most important thing is that I'm willing to walk with you on this journey to see what those possibilities are. And that's what the strengths model asks us to do, is to align with people and open ourselves to those possibilities. It's no different for me than raising the 4 children that I raise. I have no guarantees how their lives will turn out. Their lives aren't always smooth. They're challenging. They're difficult. Some days I might like them to be in a hospital. But my investment is going with them on this journey and the belief that possibility exists. The investment is there to help them continue to move forward, and that's what we invest into people's lives. There's the second side of the strengths assessment for Elizabeth. The strengths assessment is also written in the person's words. So this is not a view of the professional to the person. It's really, in a sense, beginning to reflect their hopes and dreams and desires. That's why there's I statements. I want my own apartment. I want to be able to make my own decisions. I want to get a job in a daycare center. The other part of a strengths assessment is that you will see that there are lots of goals on here, but that does not mean that our services have a role in every single one of those goals. This is not just about developing a treatment plan. Because what we don't want to do is also take ownership for people's lives and all aspects of it. What we want to do is understand that. Then we can find role. This is just some slides basically that just show kind of like those components of the strengths assessment. It's written in a context that's meaningful and important to Elizabeth. It's hope-inducing for the person. If a person typically does not have major depressive disorder, when they come into a lot of our traditional assessments, they will have major depressive disorder probably before they leave our assessments. The strengths assessment should be a hope-inducing experience for a person. And hope-inducing does not mean that now everything is better. Hope can contain difficulty and pain and struggle. Hope means that there's the possibility of a next step. That's what the strengths assessment offers. It's thorough, detailed, and specific. So it's not just about gathering a bunch of ideas and facts. It's about specifically getting into what are strengths that you could build on to be able to keep this house, or to get an apartment, to keep an apartment. The strengths assessment also evolves at the person's pace. So that's why it takes time. If a person starts to glaze over their eyes when you're doing a strengths assessment with them, you've probably done it too long. It's just to begin to capture things as you're moving forward. You're building the narrative of possibility and hope. It's done in conversation. If we do an interview where we're detached from people, if we engage in people's conversations and they can feel our sincerity, then people will give us this type of information. People are assessing us just as much as we're assessing them. Are we real? Will we be there? Where's Elizabeth now? Elizabeth now has had her apartment for 6 years. She sings in a church choir. She helps out occasionally at a nursery during Sunday school classes. She has a friend that she met, an older woman who lives right across from her, and she has a dog. So is everything perfect now? She's also been hospitalized twice in the last 6 years. She still calls the crisis line. She still struggles with depression and anxiety and disassociation and voices. But they're less frequent and less intense. So sometimes, in a sense, what we do in our work is not just to get rid of symptoms. It's to help people manage those in such a way that they can make forward movement in their life. And our belief is that as we put things in Elizabeth's life, what happened is that her symptoms started to decrease because she had hope. It was also worth putting the time and the effort into learning how to do those things. Here's the thing about the strengths model that I want you to see. The strengths model is about making shifts. And these shifts occur not only at the client level, but at the practitioner level, and even at the entire organization level, the team level. We have to all make these shifts together, or the model really does not work. Or people end up feeling like they're working in isolation. So what are some of these shifts? One of those is around hope. Think about where Elizabeth was in 2010. Her message is that I am not worth anything, and therefore this is the best that life will be, to shifting to a better life as possible. These are key components of the strengths model. But the worker was the same thing, where the case manager and the therapist were both, I am not sure that she can live on her own, shifting to I'm nervous about it, but maybe she can do it. We don't have to be 100% positive about how this will work. Anytime that we help people make movement in their life accompanies risk. But not doing anything, to me, implies more risk. The organization used to have a message which was, we have to be careful about getting people excited about their hopes and dreams that are unrealistic. Taking a risk is a liability to the organization. To a message that if people do not dream and take risks, there's no way that we can help them recover. So one of those shifts in the strengths model is about hope. Another one is about the way that we look at goals. Elizabeth's goal initially was, I'm just trying to cope. Others are making life difficult for me. And one way that Elizabeth coped was cutting on herself. She coped by going in the hospital. She coped by calling the crisis line. To now, I want my own place. I want to prove to myself and others I can do this. But this takes time to help people make those kind of shifts. That's why in the strengths model, we can't just start off and say, what are your goals? We have to let that develop. But it develops from that relationship and our sincere investment. The workers were always that, well, once you're stable, then we can work on a goal like getting your apartment. And now the worker's goal orientation is, I'm not sure what it's going to take for you to achieve this goal, but if it's important to you, I'll help you explore it and take steps. You don't have to have all the skills to live on your own to live on your own. You don't have to have all the skills to work to work. You don't have to have all the skills of how to be in a relationship before you're in a relationship. That's how we all move forward in our lives. Another one is about identity and focus. The strengths model really is about helping people relook at themselves. That's why we sometimes put those things in visible form on a tool. Some might think that, well, why do we have to do strengths assessments? Because I know these things in my head. And this is how I work and how I help people. Well, that's completely selfish because it does not give the person the opportunity to see those things visibly. Writing those things on a strengths assessment is a practice intervention itself. Elizabeth went to, I am mentally ill. You could further go, I'm no good. To, I'm a singer, I'm a friend, I'm a daughter, a member of a faith community who also struggles with depression. The case manager's view was that she's mentally ill. She's borderline. To, she's a singer, a friend, a daughter. It's really hard for people to start investing energy in their own lives if they have absolutely no identity except clienthood. It's hard to make movement in your life when your claim to fame is that I'm a client on an ACT team. I'm a person who lives in a residential facility. And that's not to say that any of those things are bad. It's not to say that those things don't help people move forward. But if that's where people's identity stops, they'll never move forward. Even the organization has to send that consistent message out that it's not that we serve people with serious mental illness. We help people with lived experience of mental illness build and rebuild lives that have meaning and purpose. So the organization has to communicate that all the way across, that this is why we do our work. Whether you are in case management, you are therapy, you are in treatment groups, you are anything. This is what we do. I want to skip over some of these things here on shifts, and I want to bring you to this important concept about helping people move beyond our systems of care. And this is concept of anchors. And what I want you to think about is not people that we're serving, but I want you to think about yourselves. All of us are anchored somewhere in our life. And that's not just our jobs. There are things that we are anchored within this city that might have to do with the things that we do for fun and the people that we see. But we have all these little anchors. And they're usually in small places within our communities. And some of the anchors that we have in our lives are more stable or firmly rooted than others. Sometimes anchors that we thought were stable in our lives start to feel shaky, or they're not as firm as we thought they would be. But who we are and how we view ourselves are associated with these anchors. So now I want to introduce also niches. Because we think of niches as these environmental things out there that our anchors are placed. And the quality of our lives is largely determined by the quality of the niches that we habitate. So there are entrapping niches and there are enabling niches for all of our personal lives. So if we think about our relationships, sometimes a relationship can be entrapping for us where that there's not much growth. It reinforces negative views of ourselves. There's no graduation or moving from beyond it. Those are entrapping niches. Versus enabling niches are those that, in a sense, start to give us positive identity. Those things that actually help us move beyond the niche that we have. It helps us to learn skills and expectations that we will actually better our lives. And we're never defined completely by that social category. Here are my niches and my anchors. First of all, there's my family. And so in my family, I have anchored things like meaning and purpose and identity, because I'm a husband, I'm a father. I get my emotional support from my family, social support. It also facilitates learning. I also have anchors in my work, which also gives me identity. It also gives me a little bit of social support, social network, and learning. I don't have a large friendship group, but my social network is primarily my neighborhood, the people that live on my block. I also have things I like to do for recreation, like play fantasy baseball and drink beer and listen to music and sporting events. But when we think about our anchors and niches, it's not the entire city of Montreal or Quebec City or wherever you live. It's these small things, and we usually don't vary too far from those. But think now about the people that we serve. Where are their anchors? Where do they derive these common things that we anchor our personal lives, like meaning, purpose, and identity, social, recreation, learning and growth, safety and security? How many individuals that we serve are anchored within our mental health system? This causes a difficult problem. It also could make it to where the strengths model is a threat to the people that we serve, because we're starting to ask people to move those anchors that have become safety and security and emotional, recreational, and social. Let's take it one other level. How many people that we serve are not just anchored within the organization, but anchored inside the worker themselves, where it's the worker in which they derive their meaning and purpose and safety and security? This is important thinking because it determines largely the success of the organization in helping people do the model effectively with people. The question is that how can we use these tools to start helping people to relook at themselves differently, to help our organizations look differently at how we respond to people? Here's one thing we've learned from the strengths model. We've been doing this for a long time. Those people that have been in the system for, say, like 10, 15, 20 years, the strengths model has done very little, had very little impact on helping those people move away from the system. Now, that does not mean the strengths model has not had an impact on helping people slowly take small parts of those anchors and slowly start to move them past our systems. But it's not had a great impact on helping people move past our systems. People that are just coming into services, where strengths model is the only practice that they know, those people are not becoming as rooted in systems, and they're leaving services earlier. This is a general experience that we're experiencing within Kansas. What this tells us is that what we do right now will shape the experiences of the people that we serve 5 years, 10 years, 15 years later. Because the people that we're serving right now have been produced from our systems over the past 5, 10, 15 years. Now, this is not to make us feel bad about our systems, because we do what we can when we can. We act on what we know when that's what we know. But there is a responsibility for us always continuously thinking, not about blaming ourselves for the past, but how do we create this future that we want? How do we create environments where when people come into our services, that they experience hope? They experience possibility. that we don't separate people from their communities. We don't just remediate deficits. We actually help invest in people's lives to help them move forward. And I'll leave that thought with you. Thank you very much. I was going to talk for about 2 more hours, but I thought you'd probably enjoy a break at some point and you might have some questions, so.
On est 8 minutes à l'avance. Moi, j'avais 9h50 pour la pause. Alors, c'est bien si il y a des gens, c'est l'occasion de poser des questions à M. Goscha. Si on a besoin de traduction, évidemment, si vous savez le dire en anglais, vous le dites directement à Mr. Goscha. You can ask him in English, but if it's not possible, well, I'll try to do my best to translate this question. Someone? And before any question, I just want to say thank you so much for this very inspiring, interesting, enlightening conference you offered, Mr. Goscha. You really set the table pour la suite de notre demi-journée. Alors, quelqu'un veut briser la glace? François. Est-ce qu'on a un micro? Exact. Est-ce qu'il est ouvert? Ray or someone else? Quelqu'un peut... Sinon, viens ici, François. Oh.
Je pense que je l'ai.
Là, il l'a. Oh, c'est beau. Bravo.
I find out. You say that in Kansas, you have 16 teams that achieve high fidelity.
16 centers.
What was the greatest challenge these teams face to achieve high fidelity with this model?
Allowing their systems to learn. Also, not to go so fast that you fail to learn. So I have a saying that's always, go slow to go fast. So not rush too quick into, let's do all the tools with all the people that we're working with, but start to restructure your organizations so that the tools and methods and techniques can thrive. So when I think about ways that we kind of support people, I want to maybe put this on up here. Am I too far in it? Oh, it's okay. But really thinking about that implementation of this model is really about organizational development and organizational learning. When people stop learning, the model dies. And that has to do with every role within the organization, from your leadership to your supervisors to your staff. We've always told teams, if you just keep learning, you will make improvement. Once you stop learning, you'll stop. So.
Pour ceux qui n'auraient pas trop compris, on parle d'apprentissage, d'évolution continuelle. Le plus important dans cette approche pour faire les changements dans les organisations, c'est le plus important, dit M. Goscha, c'est de vraiment être dans une approche. Le plus important, c'est d'apprendre, de continuer à apprendre. Et c'est déjà beaucoup parce que c'est ça qui va permettre peut-être aux choses d'évoluer. And I was just curious, Mr. Goscha, what would have been the greatest resistance, I could say, or barrier from the organizations, health system, whatever, to get this in their practice or their thoughts, philosophy?
There's so many.
I guess.
But a key element of all the sites that have been successful have been the presence of a supervisor that is a champion of the model, that is willing to learn alongside their staff and help their staff learn skills. Not a one-time training, but just learn skills over time, mutual learning. So the resistance is the organization allowing a supervisor to do those things.
And where does he come from, this supervisor?
It's because what happens in organizations is that we, in a sense, we handcuff our supervisors to paperwork and meetings and all the things that don't relate to recovery. Not that they're not important things, but we put so much of that on the supervisors that they can now no longer be teaching supervisors. So, and not only do you just need a human body to be a supervisor, it's also hiring the right supervisors. People that can embrace the philosophy, they can embrace learning, and those types of things.
Yeah, I think it's very important. Avoir la bonne personne, pour ceux qui n'auraient pas compris, par rapport aux résistances, il disait que le plus important, c'est d'avoir une personne, un superviseur, un champion recovery strength model, quelqu'un qui adopte complètement cette philosophie, qui a un rôle de coordonnateur, de superviseur, qui a un certain pouvoir dans l'organisation et qui peut vraiment transmettre ça aux autres, mais aussi avoir que cette bonne personne ait je dirais le temps pour le faire aussi, parce que parfois dans le système, il y a beaucoup d'autres tâches à faire et ce qu'on voudrait faire en rétablissement ou dans cette approche-là, bien, ils n'ont pas le temps, ces gens-là, de le faire. Donc, de leur permettre d'avoir ce temps d'appliquer cette belle approche. Une question là-bas. Peut-être le micro, où est-il rendu? François, s'il te plaît, tu serais gentil de le prêter à monsieur. Juste un instant, monsieur, ça va aller mieux. Vous n'aurez pas besoin de crier.
How important is it for the team to associate with peer support groups, job facilitators, housing opportunities, and how do you associate with these groups?
Without knowing how your groups are all structured, I will say in general that peer support should be very tightly aligned with the strengths model. I always like ensuring that teams have people with lived experience who have went through this journey of recovery that actually also helps other people make movement. So any time that we can incorporate peer support into our work, it's highly beneficial. Same thing with employment. When we think about, what are things that people need to move past our systems, one of those things is not only like identity, purpose, and meaning, but also some financial means to do that. And so employment is greatly important. And we also know that a large number of people that we work with desire employment. They may be ambivalent about it. They may not come right out and say, I'd like to get a job when they first come into services, but it's a desire that people hold. And so having the team have employment workers, peer support that are constantly thinking about what's going on in people's minds and helping them to move forward. How to do that? Part of it is that we build it into our organizational design. The strengths model has a group supervision process. And in Kansas, we have peer support and employment workers that participate as part of that group supervision process. We have to be very careful that we don't build our systems up in silos. So we have peer support over here and employment over here and housing here and a strengths model team over here. Really, the organization has a collective responsibility for helping people move forward in their lives. We need to think about is that, well, what is the role of peer support in helping people make movement? What is the role of an employment worker? And I would say, like with employment, we don't just wait to refer a person to employment. In good strengths model teams, an employment worker likes to just go out and get to know people without even knowing whether they want employment or not. Because it's all about that we're all trying to engage people and seeing if the seeds are there that we could build on.
Alors, on parlait ici du rôle très important des proches, pardon, pas des proches aidants, mais plutôt des pairs aidants, peer support workers, de les intégrer le plus possible dans les organisations, dans le système de santé, dans toutes les organisations qui viennent en aide aux gens qui ont des troubles de santé mentale, parce que ces personnes ont un savoir expérientiel, mais il faut aussi qu'elles soient intégrées dans les équipes, qu'elles soient dans l'organisation, mais transversale, donc partout qu'elles soient présentes, mais aussi que ça soit un travail collectif dans l'organisation, qu'on ne travaille pas en silo. Pour l'emploi, M. Goscha dit que c'est très important, c'est pour la personne qui, elle rêve, même si on pense que la personne ne veut pas travailler, peut-être qu'elle est ambivalente, mais au fond d'elle, qu'est-ce que c'est tellement important le rôle dans notre vie d'avoir un statut d'employé, d'avoir la partie du sens de notre vie et d'être citoyen dans la communauté. Et donc, qu'il y ait cette approche de collaboration à tous les niveaux, des gens qui travaillent à l'emploi, que ce soit les cliniciens, tout le monde ensemble, on travaille pour semer les graines, comme dit, on regarde la personne lorsqu'elle veut un emploi, pas comme, bon, tout de suite, c'est quoi, quel emploi tu veux, alors, quels sont tes rêves, quelles sont ton expérience, tes forces, tes désirs, et on regarde avec elle la personne, puis on sème tranquillement les graines pour les aider à les arroser et les pousser avec la personne. Je pense que c'est à peu près résumé très brièvement ce que M. Goscha vient de dire. Oh, so you understand French? I better watch out. Thank you so much. Est-ce qu'il y avait une dernière question? Parce qu'on va aller à la pause. On est déjà un petit peu en retard, là, c'est le contraire. Il y a un monsieur là-bas, micro, lequel fonctionne le mieux? Moi, je crois que peut-être l'autre, François, qui juste le vérifier avant parce qu'il ne fonctionnait pas le micro quand il l'a essayé, monsieur. Oui, parfait. Super. Merci.
Good morning. I just wanted to know if there was any particularities of the strength model pertaining to substance use. Is it basically the main points that we've seen, or are there any differences in the application for this problem area or challenging area?
Yes, it's all very challenging. In Kansas, we support the implementation of multiple evidence-based practices. So not only strengths model case management, but also integrated dual disorders treatment, IDDT. Back in the early 2000s, we were implementing them as separate practices. But what we realized is, number one, is that a significant number of people on strengths model teams also had co-occurring substance use disorders, and it did provide a challenge and a barrier for them being able to move forward and reach, meaningful and important goals. What we also noticed is that teams that had implemented strengths first and then implemented integrated dual disorders treatment were implementing that practice in a lot more timely manner. And they were building off these essentials that allowed them actually to help that practice become even more powerful. So what we started doing is that we started generating what we call Strengths Plus. And what it is basically we put all the foundational elements of strengths, and then once they have those skills in place, we build on top of that things like motivational interviewing, stage-wise interventions, looking at pharmacological treatments by psychiatrists. We look at specific stage-appropriate treatment intervention groups. We start to look at all those things that you build upon that are very specific to treatment of substance use disorders. But the important thing is that it's the fundamentals of strengths that start to open up the dialogue with people about engaging in those types of treatments and substances around substance use. Because it still gets at the fundamental question of why would a person want to do the hard work of giving up a chemical, a drug, giving up alcohol. You know, once again, is that a lot of times that we view things like substance use as a problem, but for that person, it might be their solution. And it's hard for them in a sense, if we go back and think of anchors, how many people have their anchors inside of the substance? So part of the strengths model is also about just engaging with people and starting to begin that journey. So it may be that we don't initially go in there saying, let's do substance use treatment, but what we're thinking about is that how do we engage this person in such a way and helping in a sense to guide their own change talk so that we can look for those opportune times to engage them further into very concrete supports that help them with addictions. It's a challenging group. At the same time as that we have had success. So when we look at strengths model teams that have also built in these other core skills of motivational interviewing, stage-wise interventions, is that we do see people that not only decrease use of substances, so moving to higher levels of stage of treatment, but then people also staying out of emergency room departments. You know, people starting to stay out of the hospital, decreased contact with law enforcement. So it's possible. Nothing in any of this work will escape us from the difficulties of what this work entails. The strengths model is not a panacea for recovery. What the strengths model does is has us re-look in how we approach people and how we view people. How do we put together those services that we already have within our systems? A lens for which that we decide about, well, which services are best for us to keep and which services maybe aren't the best ones for us to use for people. It's about helping us think differently about our work. And I think when you're talking about addictions, that is difficult.
Thank you. Je vais faire ça très très bref, mais bon, on parlait de toxicomanie, de dépendance, donc M. Goscha disait que finalement, cette approche axée sur les forces est très bénéfique également pour ces personnes qui ont, souvent on parle de concomitance, on parle de comorbidité en santé mentale, donc on a souvent plusieurs troubles, problématiques multiples. Et donc si déjà on a une approche axée sur les forces avec ces personnes-là, on est en train de déjà créer un terrain de base pour construire, aller avec des approches plus spécifiques aux problèmes de dépendance, de toxicomanie, mais c'est vraiment une façon de penser qui est différente, cette approche. C'est pas une panacée, l'approche axée sur les forces, c'est pas la solution miracle pour le rétablissement, mais c'est avant tout une façon différente d'approcher les gens, de les soutenir, et je pense que c'est ça peut-être le cœur de son message. Merci encore, Mr. Goscha. On doit maintenant aller à la pause.